Thank you. All right, Mr. Chairman and members of the board, the next item, as promised, is our Health Committee update, which we've been providing at each board meeting. So Dr. Tigan will come forward to get us started on that presentation.
Sorry, just giving you space. Good afternoon, Chairman Cooper, members of the board, and Dr. Cashwell. I am here today again with Robin Gilbert, the Supervisor of School Health Services, and also joining us is Mr. Lenny Pritchard, Chief of Operations, to provide an update on the HCPS Health Committee. Here's the agenda for today's presentation. We will share the new pandemic dashboard available through the Virginia Department of Health to include the Center for Disease Control and Prevention's K-12 school metrics. We will review the 14-day data for Monday, October 5th, 2020 for Henrico, the surrounding localities, and the Central Health District Planning Region. The HCPS Health Committee reviewed this data on Monday. We will provide an update on the presentation, on the preparation of our school facilities, and share the steps taken for the health and safety of our students and staff. This will include a review of the protocols for staff and students when signs and symptoms of COVID-19 are present. Current attendance data for staff and students will be shared, and we'll share an update on staff and family surveys and focus groups, and then remind everyone of the timeline moving forward. On Monday, September 28th, the Virginia Department of Health shared a new website dedicated to pandemic metrics. One of the new pandemic metrics is the Center for Disease Control and Prevention K-12 school metrics. Some of the reports I've shared at each work session are no longer available on the website, such as the 7-day average, Sunday through Saturday, for the individual localities. This metric has been replaced with the CDC K-12 school metrics, which includes a set of indicators for dynamic school decision-making. This set of metrics, which are to be combined with this set of metrics includes 2 core indicators of disease transmission, which are to be combined with a 3rd core indicator based on a division self-assessment measured of the ability to implement the following 5 key mitigation strategies: face coverings, social distancing, hand hygiene and respiratory etiquette, cleaning and disinfecting, and contact tracing. In addition, there are 3 secondary indicators that may be used to support local decisions. The 3 core indicators change each day and represent a 14-day average. As you may recall, the previous metrics were based on a 7-day average and reported only once a week. The secondary indicators continue to use that 7-day average. These core and secondary indicators are used to determine a risk of transmission in schools. There are 5 levels of risk, and they are the lowest risk, lower risk, moderate risk, higher risk, and highest risk. These new levels are reflected on our continuum of learning approaches, which will be posted to the website. But before we look at the data for Henrico from Monday, let's review these new indicators and their thresholds. Here are the 3 core indicators and the thresholds of risk of introduction and transmission of COVID-19 in schools. For example, if the number of new cases per 100,000 persons is between 50 and 200, then there is a higher risk of transmission in schools. Likewise, if the percent positivity is less than 3%, then there is the lowest risk of transmission in schools. This chart also provides a rubric to determine the risk level based on the ability of the school division to implement the previously mentioned 5 key mitigation strategies. All of this will be important as we look more closely at our data for Henrico. Here are two core indicators for Henrico. As of this past Monday, Henrico was at a higher risk for the number of new cases per 100,000 persons within the last 14 days, which means the number of new cases per 100,000 persons is between 50 and 200, and you see it's 90.51. At the same time, Henrico County was at the lower risk for the percent positivity in the last 14 days, which means that it is, and you see it there as 3.6%. A self-assessment of at the Health Committee meeting on Monday to determine our ability to implement consistent and correct use of masks, social distancing, hand hygiene and respiratory etiquette, cleaning and disinfection, and contact tracing resulted in Henrico being at a lower risk if using 6-foot social distancing. The only concern was the ability to consistently maintain 6 feet of space between students and between students and adults at all times. As mentioned previously, there are also 3 secondary indicators that can support the decision-making process for local communities. The indicators are the percent change in new cases per 100,000 during the last 7 days compared with the previous 7 days, the percentage of hospital inpatient beds in the region that are occupied, and the percentage of hospital inpatient beds in the region that are occupied by COVID-19 patients. The CDC does not recommend using these secondary indicators as the main criteria for determining the risk of disease transmissions in schools. They should merely support the decision-making from the core indicators shown on the previous slide. Now, let's look at the data for Richmond City and Chesterfield and Hanover counties. I will show you the same data for Chesterfield, Hanover, and Richmond in a single slide that I just shared with you in 2 slides for Henrico. And this is a request last time that I would bring more regional data. So for Chesterfield, the risk in Chesterfield, the risk levels mirror those for Henrico, but the 14-day average number of cases and the 14-day average percent positivity are lower in Henrico than Chesterfield currently. At the same time, Chesterfield is seeing a slightly greater decline in the percentage of new cases over the previous 7 days. The risk levels for 4 of the 5 indicators for Hanover also mirror those of Henrico, but the 14-day average number of new cases per 100,000 persons is increasing for Hanover, while it was decreasing for Henrico and Chesterfield. Of all of our 3 surrounding localities, Richmond appears to have the lowest risk of transmission, with 4 of the 5 core and secondary indicators being at the lowest level. The improvements seen within the central region over the past few weeks are finally reflected here. The weekly community transmission and preparedness report indicates the community transmission level for the Central Health District Planning Region is moderate, and the burden is also moderate. The trend is decreasing, which means that the decline has continued for 14 consecutive days. So what does this mean when we consider next steps for Henrico County Public Schools? The Virginia Department of Health has provided interim guidance for mitigations measures in the K-12 school setting. The 5 risk levels have been correlated to the phased guidance for Virginia schools. At the lowest and lower risk of transmission levels, schools should be using phase 3 guidance. In-person instruction should be offered to all students, providing 6-foot social distancing. If that distancing cannot be maintained, cloth face coverings should be mandated. Priority for in-person instruction should be given to pre-K through 3 students and students with disabilities, as well as our English learners. Schools should also work to maximize the use of cohorts and minimize mixing of students. across cohorts. At the moderate and higher risk level of transmission, schools should use Phase 2 guidance. Priority for in-person instruction should be given to pre-K through 3, students with disabilities and English language learners. Remote instruction should be considered for all other students. And at the highest level of transmission, of risk transmission, schools should use Phase 2 or Phase 1 guidance. Remote instruction should be considered as the primary method of instruction. And at this point, I will turn the presentation over to Mr. Pritchard so he can provide an update on facilities.
Hello and good afternoon, Mr. Chairman, members of the board, Dr. Cashwell. Thank you for the opportunity to provide an update of facilities and our HVAC system. To begin, plexiglass barriers, sometimes called cough guards, sneeze guards, desk guards, are being added in high traffic areas in schools. ACPS will also provide plexiglass barriers for each ACPS teacher at all grades, pre-K through 12, for their workspaces/desk areas. Plexiglass barriers will also be provided for individual student desks in grades pre-K through 1st. Barriers are being ordered and some are being already made by our facilities team for student small group tables in grades pre-K through 5. Cough guards will also be added in classrooms to serve our students with special needs. David Murdoch, our safety officer, and Gwen Miller with safety have been visiting schools and will visit all schools to review signage, distancing dots, sneeze guards, and furniture changes that have been made and need to be made to ensure social distancing. They will also talk with school principals or their school COVID liaison to discuss any other items or recommendations that may help each school. HCPS Facilities has created an overview of the cleaning protocols for the custodial staff at all schools. This overview was derived from HCPS cleaning standards with enhancements regarding COVID cleaning practices. This protocol also outlines support recommendations that will help minimize COVID transmission and allow for more streamlined cleaning. These protocols will be implemented to maximize the cleaning process and minimize the transmission of COVID-19. A little bit about Henrico County Public Schools and our HVAC system. Henrico County Public Schools obviously has 72 schools and centers with over 500 different systems that use 344 different filters. Henrico County Public Schools has been reviewing all mechanical systems with Mosley Architect, our engineering consultant, as well as our building automation expert, Siemens and Automatic Logic, to determine what type and extent of mechanical system changes need to be completed. Review of these systems incorporates the recommendations of the CDC as well as ASHRA, the American Society of Heating, Refrigerating, and Air Conditioning Engineers, for any system modifications or alterations. Things that we have done and will continue to do with our HVAC system. The buildings have been flush continuous air operation for 1 full week before the start of the school year. The buildings will continue to be flush for an hour each day per ASHRA's recommendation. Outside air provisions or ventilation are being maximized in accordance with the system designs. Building air intakes and exhausts have been reviewed for appropriate spacing and prevention of cross-contamination. Filters are being upgraded in accordance with the system designs. Exhaust fans are being checked and repaired to ensure operation and assistance with the HVAC systems. Building temperature set points are being adjusted to the ASHRA recommended temperature range. The BAS, the building automation system, is checked daily to review systems functions for all HVAC major components for proper operations. Any system anomalies are checked and repaired as required. We have used this opportunity to reach out to several school divisions to compare our HVAC practices with theirs. In each conversation, it was clear that we are all following the same recommendations and making adjustments that our systems will allow. The common themes in our conversations were the same as the practices that have just been shared. A few areas that are worthy of addressing our filters, and additional outside air. Our filters are checked and changed regularly. Henrico County Public Schools only uses air filters that are recommended to work properly with our HVAC systems. Filters should only be matched to compatible systems. Using an improper air filter that is too restrictive for our system may cause low airflow issues. In our homes, we do not open our windows and doors while running our HVAC system. The same should be applicable to our schools' HVAC systems as well. While HVAC systems use fresh air from the outside to regulate the air inside, each system is designed to regulate the amount of outside air needed for proper air quality and maintain an effective and efficient HVAC system. Too much outside air can impede the functioning of our HVAC system. Opening doors and windows can increase an additional allergens and humidity in our building, causing poor air quality and possible overheating and unnecessary wear and tear of our HVAC system. And now Robin Gilbert will come up next and provide her updates.
And while Robin's making her way forward, I just want to provide a point of clarification, as I just received word from Dr. Grant related to the plexiglass information that Mr. Pritchard shared that actually was an addition for the student desks he mentioned through first grade. That's actually K-12, the individual student desks, as well as the teacher spaces. I just wanted to make that clear based on our most recent order. Thank you.
Mr. Chairman, school board members, and Dr. Cashwell, in the next few slides, we are going to go through the steps we have taken to prepare for in-person learning, which we will review the PPE we currently have available, not just in our schools, but also for our transportation department and in our administrative buildings. A breakdown of the cough guard and desk shields availability, the installation of COVID-19 related signage, and a review of guidance being provided to principals on modifying classrooms, office space setup, discussion of what our protocols are going to be when dealing with a sick student or staff member, and finally, a review of the contact tracing efforts. PPE has been provided for each school to include the following items: a minimum of 4 months supply of hand sanitizer to include the 16-ounce bottles for classrooms and gallon containers of hand sanitizer for refilling these. Alcohol wipes for disinfecting of high-touch surfaces and cleaning desks and seats during student transitions. Disposable surgical mask to be utilized by students and staff when cloth covering becomes soiled during the school day or by visitors reporting to our facilities by appointment and do not have one of their own. Thermometers and batteries to be utilized for random temperature checks, for visitor screenings, as well as in the clinic and health isolation room, and for any COVID-19 task force approved school-sponsored event. 2 cloth face coverings have been provided for each employee and student. Disposable gowns to be utilized by the staff in the health isolation room and in our integrated services classrooms when deemed appropriate. Clear face coverings provided for our staff directly working with our hearing impaired student population and our speech and language pathologist. We've also ordered these for our pre-K and kindergarten students and teachers. Face shields provided to our nurses, special education staff, psychologists, and social workers, and any other employee where it has been deemed necessary based on their job function, such as for our custodial staff during certain COVID-19 cleaning procedures, and gloves. Although we still have yet to receive our full order of gloves, we are continuing to order through alternative vendors and are comfortable that we have the amount necessary for employees whose job functions require the use of these gloves for at least 4 months. Along with these items mentioned, transportation has also been provided with spray bottles and additional CDC standard cleaning and sanitizing products for our buses. To coincide with the VDOT regulations, each bus has been provided an 8-ounce bottle of hand sanitizer that drivers can refill at any zone office. Also, all special education transportation drivers and aides have been provided with face shields. Each bus has also been provided with disposable masks, so in the event a student or driver's face covering become soiled during transit, they can be replaced immediately. As a reminder, all students will be provided with 2 face cloth coverings and are expected to wear this covering, if not another one, to board our bus or come in our buildings. However, we understand we are all human and we will sometimes forget our cloth coverings. Therefore, drivers will be able to provide a disposable mask in those rare instances. All administrative buildings have also been provided with the necessary PPE that meets standards in our COVID-19 health plan. These items include hand sanitizer, alcohol wipes, 2 cloth face coverings for each employee, disposable mask, access to gloves when deemed necessary, and thermometers and batteries for screening of visitors, as well as doing random temperature checks. As mentioned in the September 24th presentation, each school has a COVID-19 school-based liaison. This person will maintain the PPE inventory for their school. They are required to conduct a weekly inventory check of all their PPE in the school building to ensure there is at least a minimum of 4 weeks' supply on hand. The school-based liaisons have been trained and provided with information on how to reorder necessary PPE. Once an order is submitted, it is received by the members of the HCPS COVID-19 task force and first vetted to ensure quality and validity. Then a member will check with what we have in stock in our warehouse to have it delivered to our schools. If we do not have availability in our warehouse, items would need to be reordered through our vendors, which is about a 2 to 3 week turnaround time. Our team at the divisional level will be maintaining a similar inventory check for what we have in our warehouse to keep the turnaround time to the schools as short as possible. In regards to cough guards, each school has received 7 acrylic cough guards. 5 of these guards are for the use in the main office and public areas, and 2 are for use by our exceptional education partners during student evaluations. These guards are to be used in locations where public interaction will be occurring. As an added layer above the recommended practices, we have also procured desk shields to be utilized in teacher workspaces, all grades, pre-K through 12. Individual student desk guards, grades pre-K through 1, and student small group tables, grades pre-K through 5, including classrooms that serve our students with special needs. These shields will be used in addition to face coverings and social distancing. And as Dr. Cashwell said, we have upped that order to cover more of our students as well as all of our teachers. This is just one example of how HCPS is prioritizing safety and raising the level of comfort for our staff in returning. This will be important for our teachers to have an additional barrier when face coverings must be removed when students and teachers eat lunch in the classrooms. Guidance has been provided to the staff on the installation of signage at each school building to include CDC signage specific to hand washing procedures, help stop the spread, COVID-19 symptoms, prevention tips for employee workrooms, break rooms, and face cloth covering reminders. Signage has also been provided to include the new COVID-19 screening procedures of visitors before being allowed to enter the building. In addition to this signage, 6-foot adhesive floor dots have been provided to each school to install in high-traffic areas where the likelihood of a line might be forming, such as in the main office area. As we see a return to in-person learning, there are additional areas in the building these would be installed, such as in the cafeteria or library. Each school will modify the layouts of the classrooms to ensure that social distancing is maintained. Occupancy will be limited to support physical distancing of at least 3 feet, specifically on buses, but aiming for 6 feet to the greatest extent possible in our buildings. Social distancing can be accomplished by removing the appropriate chairs, but leaving the associated desk. The desks are not intended for seating, should be marked as not in use with signs or tape. Leaving the desk will assist in physically maintaining social distancing, while removing the unused seating will help streamline the cleaning process. The Division of School Leadership developed a checklist for safe classroom configuration. Furniture adjustments are also being made in public areas as well as our staff workrooms and break rooms. Staff from the Facilities Department and the School Safety Office have been visiting each school to review replacement of signage, cough guards, and furniture changes. They have also assisted in determining where additional cough guards or signage would be required. This information communicated with the principals and the COVID liaisons, along with documentation of the school's preparedness with recommendations for changes or additions. This process is ongoing to ensure continued compliance. Now let's transition from facilities to the protocols for when students or staff become ill with COVID-like symptoms or have been exposed to a COVID-positive person. This is a partial snapshot of the Virginia Department of Health algorithm for evaluating a child with COVID-19 symptoms or exposure. The algorithm provides guidance for parents or guardians, schools and child care facilities, and our health care providers that all lead to a return to school recommendation. This is what will guide HCPS. This guidance will apply to students and our staff. Simply put, if a confirmed case of COVID is reported, the Virginia Department of Health, Henrico Health Department, will be notified and a list of close contacts will be provided. All confirmed cases will be required to isolate at home for at least 10 days. This comes from the start of symptoms or date of their positive test. At the conclusion of 10 days, and at which time the student or employee has been fever-free for over 24 hours without the use of fever-reducing medication, and also has experienced improvement in all other symptoms, then they may return to school. Student absences due to quarantining or isolation will be tracked through our PowerSchool. All close contacts of confirmed cases will be informed by the school of their exposure and kept out of school for 14 days from the date of their exposure. If the contact never develops symptoms or never tests positive, she or he may return to school or work after the 14th day of quarantine. If he or she develops symptoms or tests positive, the contact is now a case and the case protocol now applies. This means that the school reports this to the Virginia Department of Health, Henrico Health Department, and the contact then isolates, or the positive case now isolates for 10 days from the onset of their symptoms or their positive test. A close contact is defined as someone who spends a cumulative amount of time of 15 minutes or more within the 6 feet range of another person. The use of a face covering is not a mitigating factor when we look at contact tracing or the assessment of a close contact. Overall, teacher and student attendance is another factor being monitored. The data for the first 4 weeks of school is shown here. While there is a deviation from school to school, we have averaged 1 teacher absence per school per day. When teachers have been out, whether taking a sick day or an extended leave, we have been able to provide a substitute 95% of the time. Student attendance is also being monitored, and efforts to engage or re-engage students has been ongoing. We currently have an 86% of students having meaningful interaction and/or contact with their teachers every day. For those students who are not having that meaningful interaction each day, school attendance teams continue to meet and discuss ways to increase the daily interactions. Attendance conferences are also being held as they would if students were in person each day. Social workers have been reaching out to families of students who are considered truant. As we seek to keep staff and students healthy and participating in the learning process, it is critical to seek their feedback. Dr. Tigan will come forward to share our efforts in doing that.
A staff survey and a family survey was launched on Monday, October 5th, and responses are due by Sunday, October 11th. While there have been some questions about responses, every family or staff member's response was tied to their email, and duplicate responses were not possible. The family survey was provided in English, Spanish, Arabic, Dari, Nepali, and Portuguese, and schools were able to provide paper pencil copies to their families, and that could be done, they could come into the office, or they could pick them up when they were picking up meals, or get them from the buses through meal delivery. The communications team created an informative video for families and staff to highlight the comprehensive steps taken and mitigation strategies in place to ensure the health and safety of staff and students during the current limited in-person instruction. Also shared in this video were the staff training modules, which included guidance from the CDC, the Virginia Department of Health, the Division of Labor and Industry, and the Occupational Safety and Health Administration, or OSHA. We hope this visual helped families and staff see what in-person instruction looks like. The responses from our families and staff will provide insight into their needs and will help us understand how they may approach a shift should we move to more in-person learning. This will help inform planning efforts moving forward. Additional feedback is also being gathered through staff and family focus groups. The participants are providing important feedback on various aspects of the potential models, as well as how they feel about the mitigation strategies and their application. We continue to expand the number of students coming into our schools each week. This week, some of our career and technical education students have been spending time at the ACE centers and at the home building site, being able to apply their recent learning. The limited in-person opportunities have given us a glimpse of how well teachers and students are able to apply and the impact of, again, those mitigation strategies outlined in our health plan. In addition, to evaluating our current in-person models, staff have also been examining in-person models from around the state. We have also looked at the child care programming sponsored by the Henrico Police Auxiliary League, the Henrico Education Foundation, and the YMCA, which are currently serving students in grades K through 8 in our classrooms. These providers, who have a long-term relationship with our schools and our families, have been required to follow all aspects of the Henrico COVID-19 health plan. This includes utilizing all of the mitigation strategies and protocols. As we come to the end of week 5, I am happy to report that there have been no cases of COVID-19 amongst the nearly 700 students and staff. As we continue to monitor our health data, PP inventory, and staff considerations, we will continue to look forward. We will provide an update and bring forth a recommendation from the Health Committee for the second 9 weeks at the October 22nd school board meeting. The data from the family and teacher surveys will help inform this recommendation. If there is a decision to provide a different learning approach for the second 9 weeks, families will tentatively have from October 23rd to the 27th to share their intent. This time frame is aggressive and could shift based on when staff are able to finalize the intent form after the meeting. While this is a short window, families were informed there would be an intent form once more details were available after the October 22nd school board meeting. Schools will need every second of time to follow up with families who do not respond in order to be ready on November 16th. And at this time, we would be happy to answer any questions you may have this evening.
Thank you so much, Dr. Tigan.
You're
Thank
welcome.
you so much, Ms. Gilbert. Thank you so much, Mr. Pritchard. I'm going to begin to my right with Ms. Kinsella.
Yes, thank you so much for that presentation. With the majority of the feedback I've received in the Brooklyn district, emails, comments, and just other conversations, whether it's at the grocery store, out in the neighborhood. The Brooklyn District continues to support prioritizing the health and safety of everyone. And with that in mind, and as we look at the timing of potential options for second quarter, possibly in-person return, I think about the holidays. And are we considering the timing of the holidays in our plans and how students are coming home from college for Thanksgiving and how families will celebrate and maybe not be as cautious and safe, and potentially we could all have COVID by Christmas?
We have talked about different strategies of, if the health data would say that, we can consider a more in-person return, what that would mean, but no definitive answers. We don't have any definitive answers at this time.
So just to set the record straight, for those who may have emailed about that, we already have a plan. We do not have a plan.
We do
That's
not.
That's what the survey was for. Just thank you for clarifying that. And I just wanted to go on the record saying I'm thinking about the holidays, and that concerns me. So I'm thinking about being creative and having options, potentially phasing in, a small group phase in, or thinking about January. But I just wanted to be able to say that. I've also heard from parents that are concerned about what will happen to the staffing with the students who have chosen virtual. If in-person options come to fruition and are feasible. Can you tell me what our thoughts are as to how we would look at virtual staffing or in-person staffing?
We have continued to share that there would be an option for our students to stay virtual if that's what they wanted. Looking at the data is really going to be key to knowing how you would make the classes and whether that would be that you would have a change. That's where we said you may have a change in teacher. It could be an in-school person that the in-school students have a change because more of the class wants to stay virtual or vice versa. But until we have more definitive data, and that's why we were asking our families and our staff to really take this seriously, because this is what we need to help guide what our options are.
Okay. And then, let's see, as we provide details to families about the next phase of the process, do we know when we'll release the survey data? If surveys close on the 11th, when do you think we may make that information public?
It will probably be at the end of the week would be the absolute earliest, more likely the Monday after.
Okay.
Because we still have to enter some of the paper pencil and go through, be able to go through the data and create the reports. So it takes a little bit of time.
Okay, so definitely before, potentially the Monday before the meeting on the 22nd.
Yes, I definitely want to have that information to take to the health committee that Monday.
Okay. And then are our attendance rates right now virtually similar to in building for the same time last year? Are we experiencing more absence, or do we know?
Building by building, I can't tell you that. On average, we're probably a little bit higher on absenteeism.
Okay. And then how were the focus group participants chosen?
There were participants that the directors worked with to recruit people at each level within each magisterial district.
Okay.
For our parents and our teachers, and then we had specific groups related to whether it was the EL population or the special ed population with the teachers and parents whose kids were participating.
Okay, and then last question. With more than 5 languages spoken in our schools communities, how else are we making sure families are able to fill out this survey and their voices be heard?
Going through our schools, and we know we had our Welcome Center on standby if families needed assistance,
Okay.
that schools could reach out and help connect our families to the Welcome Center.
Okay, thank you.
You're welcome.
That's all.
Thank you, Ms. Kinsella. Ms. Ogburn?
Real quick. Dr. Tigan, I have gotten actually a couple of complaints about the mask video that you referred to, and that there are basically not wearing masks properly. So I would ask that you might, or you or the team might review that to be sure. I haven't seen that video, so I'm just passing that along, that there are people who think it's not quite right. But I really am glad to hear our review of available PPE and protocols, and what that is the thing I'm hearing from parents the most that they want is what are we going to do when a child gets sick? How do they know that? And how are we going to contact trace it and all of that stuff? So I'm really glad that y'all have brought that forward right now, especially following our in the time that our survey is out, because that is a pressing question from parents. But that's all I have. Thank you.
Thank you, Ms. Ogburn. Mrs. Shea?
Thank you, Reverend Cooper. And thank you, Dr. Tigan, for taking time to do this presentation. You know, there's a lot of misinformation out there, and it's circulating very quickly. And I think it's so important to, take time for you and Ms. Gilbert and Mr. Pritchard to provide kind of the factual information as much as we can. So thank you for taking time to do such a detailed report here. I do have some questions. So let's launch it. Let's start with health metrics if we can. On slide 5, okay, so we have our new adjusted health metrics, which I really appreciate that they're now out there for the community to be able to access, whenever they want to, and they can tab between different counties. I think that's really a huge step in transparency for our community, and I know we were waiting on VDH for that, but I appreciate that, and for Mr. Jinks for linking it to our webpage to be easily accessible. So the number of new cases per 100,000 being one of the core indicators there. Do you know if this number includes congregational living facilities within Henrico's boundaries?
It does, and that's one of the reasons why we work so collaboratively with the health department, is so that we know the underlying story behind the data as well. And so having Dr. Avula with us at each health committee meeting is really critical for us. We have that as an added benefit. We don't have to just call him, he actually sits with us.
That's fantastic. So for example, if there was, let's say, a significant outbreak in a congregational living facility in the next few weeks, which drove that number up, the health community would be able to talk with Dr. Avula to understand that and almost kind of subtract out that effect. So while the color might be whatever it is, the health committee is looking at the real picture.
Yes.
Fantastic. Also looking at, so we've got to be at, I think you said 50 cases per 100,000 to get to the lower level. So 50 cases over 14 days, that's about 3.6 cases per day per 100,000. Henrico's got 300,000 roughly. With some Fermi calculations here, 300,000. So, ballpark, that's 11 cases per day on average that we're looking at per 100,000 to get to that level.
Right, but I would caution, because it's not like one of the levels takes you out. It's looking at the comprehensiveness of the data, just to be clear.
Thank you. And so that was, really one of my other questions is when we look at our core metrics and our secondary metrics, how is the health committee determining the overall risk level? Like if it had to boil down to one, are we just looking at core? Is it an or?
We started with the core. Now realize we've only had this since this Monday, but the committee started with the core, and then we looked at the secondary. And a big part was the ability, a large part of the discussion was our ability to implement those key mitigation factors. And so those together was discussion and group decision on where we landed, and that's where everyone felt like we were borderline between the lower and the moderate.
So it's not necessarily an average. You're not taking an orange and a green to make a yellow. It's a contextualized decision using these metrics with the experts on the health committee.
Right. And then if you look at that and then you look at this, it'll help guide you where you fall. You know.
Okay.
Right, it's contextualized.
Yeah, that's helpful for transparency. There's some people that want to know, like, I want to see, exactly what we're looking for, and it's hard as a quantitative person to embrace the contextualized, but I understand why it has to happen. And, when you say you're most concerned about this ability of schools to implement the 5 key mitigation strategies, some of that's really going to start at home with our students before we bring them into the building on dependably and correctly wearing a mask, for good hand washing practices, for respecting social distancing and those things. And so my families are always asking, what can I do to help get kids in the building? And I think these 5 key mitigation strategies could be things they could be working on, so that when we get in the building, we can help stay in the building by showing that we're able to adhere to those. And then on slide 6, I know these are secondary indicators and not a primary concern, but just to help understand the context. So when we look at our percentage of hospital inpatient beds, as well as the next number for hospital patients, is that in that entire central region that we've talked about?
Yes, these are the region factors, not Henrico County.
Okay,
Correct.
and so it makes me feel better that they are secondary as opposed to core, since they're not as granular as our kind of immediate area. And y'all will be considering that as well as you have your discussion, that
yes,
the larger area.
And that is exactly why they are secondary indicators and not core.
Thank you so much. Yeah. All right, let's move on to in-school things. Dr. Cashwell, I know you've interjected some clarification about the plexiglass. I just want to make sure that's clear and I'm really clear. So your interjection, did I hear you correctly that we now have plexiglass shields for all students and teachers' desks K through 12?
They've been ordered, that's correct. The ones that I think have been secured in hand are the lower grades that you heard about, but the additional order that was placed was for the individual desks at the secondary level as well. That was the part that was missed in the original script.
And so in terms of furniture, particularly for our elementary, they may still have tables, group tables, but they will have plexiglass shields in between them.
That's right. Actually, the elementary classrooms, pre-K through 1, I believe there are additional, some that aren't necessarily the individual desks, but as well at some of the small group tables or different configurations that can be used rather than just the single desk, which would be at each person's desk. And then at the tables, you may see various configurations where students might have manipulatives to work or sit at a round table. You might see something different in the plexiglass arrangement. But yes, plexiglass for those spaces as well as the teacher spaces.
Well, I know that has been a significant investment, and I appreciate the prioritization there of student safety. It'll be interesting to see how they work on some of the slanted secondary desks, but we're problem solvers, so.
That's right.
I also, Mr. Pritchard, when you talk about HVAC and all the many, many things you've done assessing our HVAC systems, would you say it's accurate to say that we should expect our HVAC to be better functioning this year than in a traditional year?
I mean, I would hope so, with all of the maintenance and prevention stuff that we've been doing and extreme monitoring. And not to say that we haven't in the past, but I mean, it has been our priority to make sure that we are doing this and meeting with our engineers and consultants. At least, I think we moved that back to the point now we're meeting with them every 2 weeks now instead of weekly. But these things are monitored on a day-to-day basis. So hopefully, yes.
So when I hear a teacher share that, sometimes my room doesn't have HVAC or it's broken, we are being proactive to prevent that from happening this year.
Yes,
we're always proactive, but we're being particularly proactive this year about it.
And we just went out to some of our schools and did some random checks on temperature readings, humidity in rooms, CO2 output and input and all that wonderful good stuff. We are going to start getting into areas that I'm going to have a hard time explaining myself, but I have become a much better authority on HVAC systems. But we have randomly gone out into schools and start checking these things as well. So I think that we're doing everything that we possibly can to make sure that that happens.
Thank you. And I also appreciate your context about the windows and how they relate to HVAC. I know this summer, that's what I constantly said to my kids, I'm not paying to air condition the outside, keep the windows closed. But, as you articulated, that our systems are calibrated for a certain amount of fresh air flow. Particularly I have two schools that have very few windows, but for you to put that in context, that's not impeding their air quality. The systems have been designed that way.
Yep,
and you would recommend even people who have windows not regularly keeping them open with the HVAC because it will impede the air quality.
Mm-hmm.
Okay, thank you for that. I think that those are my only facilities questions for you, Mr. Pritchard. Going a little bit to contact tracing, I know this has been where there has been a significant amount of misinformation. And so I know, Ms. Gilbert, you spent some time talking about this, but I just want to be explicit. If someone is traced for exposure, so there's a positive case and our contact tracers trace for exposures, and they decline testing, they are still required to quarantine, correct?
Absolutely, for the full 14 days.
Okay.
And even if they go for testing and come back testing negative, they still have to self-isolate for those 14 days.
Oh, wow, okay.
That is their measure for allowing someone back in the building, student or employee, is the 14-day period.
Dr. Teigen and Dr. Cashwell, I would imagine that as we develop any sort of instructional plan for second 9 weeks, that plan needs to be robust in terms of having our students that are in the building who may have to quarantine for 14 days to still be able to have access to content and instruction, and that's something we're considering.
And Ms. Shea, to clarify, the 14 days is because during that time period, someone can convert to positive. So if they get that test between day 3 and day 5 and it comes back negative, that does not rule them out from converting to a positive case during that 14-day period.
Right,
so
and
we're
then
not holding them out.
And then if they ended up developing symptoms or testing positive after that, that would trigger 10 days.
Yes, ma'am.
Okay.
Yes, ma'am.
Yeah, so I think it's really important, any instructional mode we look at for second 9 weeks to make sure that any in-building students that would have to flex to virtual would still have access to instruction, because that could easily almost be a month of missed instruction if it isn't. So that's an important piece. Thank you for clarifying that. I think that's has been a great concern for our parents, and I suggest any of our community who starts to hear pieces like that to always refer back to our health plan. It is put out there and has a lot of these details in it. Correct me if I'm wrong, but our health plan has not changed since it was developed and filed with the state. And so while it is long, it is, there are a lot of details there, and we will be following health mitigation strategies regardless of what happens second 9 weeks. Correct. Thank you. Just a couple more questions. How will non-compliance with health mitigation by students be handled if we resume in-building instruction?
The behaviors will be handled much like they are now, where, some of it is understanding why the behavior and being able to counsel that child, have conversations with the parents. But the expectation is that with these mitigation strategies, we need compliance. If a child doesn't have some type of medical condition that they've documented through their 504 IEP plan, that there's an accommodation. We would expect all of our students to wear masks all the time. Now, we have discussed areas where there could be mask breaks, where, we've asked Dr. Hughes's team, they have worked with the health and PE to really work on providing activities for teachers that will allow students to be 6 to 10 feet apart outside. And then that will give them a chance to not have a mask on. In classrooms with recess time, that if students are spread out and not congregating, that they could have some mask-free time. But inside the building, the expectation, inside the building or anytime they're not 6 feet apart and maintaining that 6 feet apart, they need to be wearing their mask.
So these masks breaks would be for outside time?
Yes.
Okay, we'll just keep going there for a second. At lunch, talk to me.
Okay. So at lunch, they obviously would not be wearing masks when they're eating. That's not feasible. And so that is one of the reasons for the desk partitions, is so that will provide a double barrier between the student and other students, as well as between the student and the teacher, because they'll have their own partition as well, that sneeze guard at their desk.
Would we be able to utilize outdoor space, weather permitting, for lunch?
Absolutely.
Okay. I know. Okay. Thank you.
Fresh air is good for everybody.
Especially this kind of weather. I put my window up next to my desk. It's good for the soul. Back to our non-compliance with health mitigation. I would really like to see, before we move any students in the building, some outline of what the discipline might look like, particularly for, there's accidental and especially for our younger ones, the learning process, but there's also perhaps going to be some, defiant non-compliance, and I think we need to have some conduct procedures in place for that, because it would truly be at the detriment to the health of the other students. So we need to have some plans around that.
Absolutely, and I'll tell you, we have talked to some of our local regional partners that have been in school doing in-person learning since the beginning of the school year, and mask compliance, they say, has not been an issue. It's, there's an understanding of a different understanding level, and so, I'm optimistic. Now, of course, we'll have plans in place, but just the feedback anecdotally we're getting from others is that has not been an issue. And we've also gotten that from our students that are participating in the limited in-person, as well as our child care providers. That, the wearing of masks, and, once they're shown how to wear it properly, some come in that way, but others have to be taught. But there's not been an issue. And, some of our children in there are middle school, and I think we think of middle school children as the ones sometimes wanting to test where boundaries are, and there haven't been issues. So we are optimistic that will be something that will be across the board when we come back, if we come back.
Well, I'm really encouraged to hear that, as well as the report that there's been no cases in the near 700 kids that are currently following our health mitigation plans in the building.
Or adults. I mean, that's adults as well.
Two more things. Can we talk a little bit about social distancing? Because, part of our health mitigation plan is we will maintain social distancing. However, there's a lot of definitions of that. So I know that 3 foot is really, the buses are going to have to be closer to 3 feet. How about our classrooms? What distance are we looking at?
Optimally, you're looking at 6 feet, but, we know that with masks, you can go down to 3 feet. That's what many of our, of the other localities that are back are. But our goal would be to look at the numbers and try to spread out into larger classrooms, larger areas if we needed to provide that greater distance. And another thing is being able to put more distance between the front of the room where the teacher is and where the students are, and making sure that that's a good 6 foot distance to help with that social distancing between the adult and the children.
And this is a very specific social distancing question, so you feel free to get back to me if you need to. But I've had some questions come in on how is that 3 feet being measured? Is it like midline to midline of the students, or is it essentially like between desks or between seats for students?
I mean, technically by the CDC, you're going from midline to midline when they're talking social distancing, because it's about where the air is coming from.
And then my last question, we have arrived at the end of my list, thank you for your patience, is I know some of our families had a lot of frustration with the lack of details in the survey. However, it's also not quite possible to give details in the survey. It's almost like the chicken or the egg. The survey is not a popular vote. It is an intention to understand the volume of students who might be returning to the building and staffing as well, right? And so it's a data point to understand what plans may be feasible and what won't. So all those details can't come forth because we need the survey to make all the details. Before the family intent, that window that you discussed there, will those granular details be available?
Yes. I mean, that's, you know, that the details have to be built for every plan, and then whatever the plan is, you know, you have to then transition. So that's the work of the staff, to have granular details on every option.
And I know I'm just wanted to clarify that for some of our families that have a lot of confusion right now. And that's why the survey right now was non-binding as well. Will it get down to the detail of whether a specific student would be able to keep their teacher?
I don't want to promise something that I don't know that we can do. It'll depend on what the results are and what the option looks like.
All right. Thank you so much. And then the very last comment is along the lines with Ms. Kinsella. When we look at our plan and when we see because I think this November versus January issue may also depend on the plan as to what's feasible or not. But if it's a plan that could feasibly allow for our students who want to return to the building to choose November or January, it could provide almost a natural phase-in into the building as well. But I know all of that's, again, going to depend on the survey results and what plans are feasible. So I thank you for your time and your detail and your team's just tremendous work looking at all the angles.
Thank you, Ms. Shea. Ms. Atkins?
Thank you, Chairman Cooper. So prevention has and is currently and will be in the future a focal point. So whether you are in person or at home, prevention is key. And I know that HCPS is taking every precaution around what can we do to prevent the spread of viruses and diseases. And top of mind right now is COVID. But there are others, just like flu and other diseases and viruses that come to our schools. And I know, and I'm really, really pleased in us securing the appropriate PPE, not just like the face masks that you and I have on, but masks that are specific to the roles that are in our buildings. That is important. So kudos that we've accomplished that. That is a check mark and a step in the positive direction. I do have some questions for Mr. Pritchard, if you don't mind.
No, I'll step back and give him some space.
Yes, ma'am.
So I know we have talked about plexiglass often, and I'm glad that we've secured that. Can you share with me some of the preventative measures and how we're going to use that in our clinics and our bathrooms?
I know in clinics, I'm going to defer that because I think the expert that deals with clinics parts should be able to answer that for you.
Absolutely. Thank you.
Ms. Atkins, was your question how we're going to do with airflow in the clinics and the isolation rooms?
Yes. Mm-hmm.
So, and I'm going to use the wrong terminology here because I'm medical.
It's
but
fine.
in working closely with the counterparts under Mr. Pritchard, there are going to be special filters, air filtration systems that are put in there and are being ordered for the clinic as well as the health isolation room. So there'll be additional filtration of that air in those areas. as well as when the area is used, or if we have a suction room that's being used for a child with that level need, there will be special cleaning procedures that will go on in there. And the suction room would sit for a full hour before we go back in there to clean, so that any aerosolization will have settled.
Okay, fantastic, because there is a separate process, as you know, that is used.
Yes, ma'am.
For that, so I'm glad that we're looking into that and trying to find the appropriate and maybe affordable way to do that, right?
It's my understanding
because money is an important part of this discussion, and so when we think
absolutely.
about the bathrooms and the clinics, I'm really glad that we're in the same place
Yes,
in the
ma'am.
decision-making there. When we think about the clinics and isolation rooms, aside of the filtration, can you share with me the cleaning protocols from the janitors?
So for the clinic and specifically, which will be our clean area, so our healthy children will be coming in there to receive their medications, or if they have an injury, EpiPens, those types of things. Our routine chronic condition children will be coming in there to receive their care, and we will continue to clean in there as we normally have. High-touch surface areas. Our health isolation room, which will take in any of our sick children with any type of symptom, those specific to COVID, would be more frequently cleaned by our janitors. The floors will be mopped. We're going to have cots in there that can be wiped down. They would be wiped down between each child. The staff going in there is going to have all of the PPE, including what you mentioned, which was the N95 mask, which we are fit testing our staff for. That process is already in place and being done as we speak. But they would have all of that type of PPE to put on for protection. And then, of course, donning it and doffing it before we come out, covering those trash cans so they're not accessible to anyone coming and going. And again, just the entire room being wiped down, and basically everything out of the room is being taken out except what's absolutely needed.
One recommendation that I received to explore, and I'm going to explore it myself, is looking at the trash cans in the bathrooms and in the clinics, and exploring the possibility of filters for our trash cans, or just a cover. And so I think that's something we want to take a look at. And as I get more information around garbage disposal, I'll share that as well.
That would be great. And the covers are being ordered for the isolation rooms in specific. Those trash cans will have lids.
Fantastic.
Yes,
so
ma'am.
Thank you so much for that. And then the piece for the bathrooms, if we don't have that, it's fine.
No, I mean, and part of it is, I think that some of that's going to be school-based on how bathroom implementation is going to occur, knowing that having been in schools, and at least in my experience, that you do have stall areas and you do have dividers between urinals as well. As far as plexiglass goes, I don't think that was something that we've really had a discussion about yet. So being that it was a concern, but it's something that we'll definitely raise and have a discussion about and see what we can do as far as that. The terminology that she was looking for was called air scrubbers.
Fantastic.
You're
That's
very welcome.
exactly right.
Yes, you're very welcome.
And so, and again, this is also something I'm looking into as well when we think about our bathrooms. So some bathrooms are open bathrooms without doors. Some bathrooms have the shields in between, particularly our female or girl bathrooms where we have separation in between. But there are, once you come out stall, you have the sink. And so some things that I've seen in some innovative design is having that plexiglass between the sinks. I don't know if you've seen that, but that's just something to take a look at. It might be helpful as well. And then also looking at some of, I think the paper towel roller where you do this little piece is still in some of our restrooms. And so let's take a look at how we're doing that to wipe our hands once we wash
Well,
them.
I know in the restroom part, we are blocking off every other sink so that there's some kind of distancing that will take place as far as that goes.
Fantastic.
Yes.
So thank you so much for that. I
Yes.
think that actually concludes my questions on that, but I do have some questions around training.
Okay.
Yes, ma'am.
Thank you, Dr. Teigen, for coming back up around training. So part of being preventative, and Mrs. Shea alluded to this a little bit earlier, is really around learning and learning how to have this new habit of wearing a mask. So for some of our families that do not leave the home often, it may not be second nature to automatically put the masks on. And so to develop that habit, it does take time, and it does take training. Will you share with me the trainings, one, that our staff have already been participating in, and then share with me the discussions that are taking place on habits of wearing masks and healthy ways to sort of live in our school buildings?
There have been 3 trainings to date for our staff, specifically around COVID-19. One was about the mitigation strategies of wearing masks, how to wear it properly, proper washing of hands, that it covered all of those mitigation factors, how to sneeze. And a second one actually talked about the isolation and the self-monitoring and making sure that you're not coming to work sick, and what to do if you are, and those protocols. And then the third one was directly aligned to the Department of Labor and Industry about the level of PPE that's required and how that has been determined job by job, classification by classification. And so those are the 3 trainings that our staff has had. And there has been, I believe, 1 video for students on the mitigation factors as well that was for the younger kids, I believe, that has been pushed out.
That's
Right? That's what I thought.
Has there been any training? I know so far it's been more physical. Is there any around mental, the anxiety of COVID, the understanding that I feel a little angst when I have to enter the building because of COVID? Is there any mental well-being training being done for staff?
On an individual level, but not across the board.
Okay.
We have, across the board, we've reminded staff about EAP, and we've provided other opportunities that we've advertised through Schoology that are things that are available if there is that kind of stress. And I know that our counselors are working in their schools. They're doing some group work and working with individual students, and they're doing that virtually. So even if the students aren't in school, they are still having that time with their counselor and with that group session.
Thank you for that. What's interesting is each individual has their own level of understanding when it comes to their mental well-being coupled with COVID. We might want to explore doing something short, whether it's a video, whether it's a handout, more general level of how to handle angst and anxiety. So, for the staff member that is healthy but is concerned about bringing something home. If the staff member is concerned about interaction with a student that may be coughing in the classroom, of course, that may not be COVID, but certainly there's a lot of misinformation out there. And I think, addressing the physical is critical, but addressing the mental is equally. And so what you shared with me is the independent opportunities for individuals through HR and other avenues, but I'd like to see some sort of collective, high-level, general way that we can become more comfortable in our school buildings mentally. So just something to share with you to think about and explore as well.
And I'll follow up with Dr. Hughes as well, because I think the counselors have provided some things to students, but I want to verify, and I'll get back to you.
Fantastic. So thank you so much. And so now I'm going to talk right to my district, Highland Springs, Sandston, and Varina. I want to make it very clear that no decisions have been made. I'm also going to make a very clear statement that I have not made any decisions. And the reason why I have not made any decisions is because I also am awaiting more information from our school division, and I'm also wanting to get more information from you. So whether you want to send an email, whether you want to give a phone call, send a text, or if you're joining me at many of the events that I'm going to have over the next 2 weeks, I am asking, I am begging for you to reach out to me and let me know what you want. The reason that I am in this seat is to represent you. The most effective way that I can do that is to hear from you. And to serve you, I have to know what you want. I'm just a vessel carrying a message. And that message should be dependent upon what your wants, needs, and desires are. So please, please, please continue to reach out to me so that when October 22nd comes and a vote is made by me, it is not just my thoughts, it is not just my opinion, it's a collective of information from the division and from you. Chairman Cooper, the floor is yours.
Thank you, Ms. Atkins. Real quick, Ms. Shea, redirect.
Yeah, absolutely. Dr. Tigan, I was just thinking as we were going back, I believe it was in July, you brought forth a slide about things that would look different in school. Or at least somewhere along the way you brought us back. That's like, I think that would be very helpful for me as a board member. I don't know how my other board members feel as well, but whatever plans or recommendations are brought forth for the next meeting on the 22nd, to have a slide that really delineates how that looks different from a typical year. Right. And so I know for elementary, it might look one way, for secondary, the other. But, for those, we know that anytime being able to, whatever returning to the building may look like whenever it happens, it's not going to look, there's going to be differences from a typical year. And I think helping us understand what they are and helping the community understand what they are is going to be of paramount importance. And so I loved that slide. So if we can update it and bring it back, I would appreciate that. Thank you.
You're welcome.
Dr. Tigan, a couple of quick questions. I noticed that you mentioned earlier in regards to the dissemination or disaggregation of the data for the surveys that there's the possibility and potential of teacher change. And so I know that we have not necessarily added meat to the bone in regards to the micro information pertaining to that. But in that process, have we kind of thought about whether the expectation based upon the data would include our teachers having to dualistically instruct, i.e. virtual and in person, or can you just help me feel good about just the disaggregation of the information and the application of what our expectations may be?
I mean, we have had conversation about that. We have singleton courses at the high school level, at the secondary level, that might not allow for a completely virtual teacher and a completely in-person teacher, and so looking for ways that may work. And it's not saying that teaching both at the same time is the only way it can work. We've talked about how could you schedule a day to make that possible, and so those are still things that are in the works, as trying to figure out what options there are.
Okay. So that we have that as a high priority in trying to make sure that it's the best for our staff as well as our students.
Yes.
Another question in regards to the health committee. So on Monday, I'm sure you're cognizant because you're on the committee, that the CDC admitted that COVID-19 can spread through airborne transmission, meaning small droplets and particles that can linger in the air for some time after an infected person even moves away. Also, the CDC admitted that the coronavirus may be able to infect people who are farther than 6 feet away from the person who is infected or after that person has left a space. So I guess my question is, can you kind of speak to how the Health Committee is taking this new information into consideration and how this impacts in-person learning?
Well, and I think some of it is trying to look at it in context. As Ms. Gilbert was sharing about contact tracing means you need to be in with that person for 15 consecutive minutes within a 6-foot space. And so what does that mean in a classroom? And those are conversations that the health committee will have, and with Dr. Avula and others. We have epidemiologists that sit on our committee that are able to help decipher what does that really mean in this situation. I think there's so much information out there, and it's how do you really take all of it to say what does that mean for us in our situation.
So, and for me, specifically, I know you mentioned the partitions that separate students from teachers and students from other students. I guess for me, I definitely want to kind of hear more about how that is applied specifically to the lunch environment, as far as the lunch eating in the room. Because I think that's definitely applicable in this kind of context as we contextualize it.
Absolutely. I mean, that's one of the main reasons, as we worry about kids and do they know to keep their hands to themselves when they're young, but then when they're older, you're still worried about what are the other things that we need those barriers for. And so they serve different purposes, but that is the reason why we're doing them pre-K through 12.
Okay. Quick question in regards to the survey. So we talk a lot about, the different languages that we have in our division. What about magisterial district response rates to surveys? How do we ensure that if, for instance, two districts respond more than another district, vice versa, how can we get kind of this method in place that speaks to equity in regards to receiving input from constituents from across the county and not just those who may be the loudest, the most vocal, or the most organized?
And that's why we try to employ our principals where they have connections within their communities and with them reaching out to their communities and providing that opportunity for them to come in and be able to sit down and someone to go through that survey with them, whether it's in person, whether it's by phone, just trying to make sure. I mean, we do have data. We know where the families are. There is some crossover. They might live in one area and go to school in another. But, that data is tied to their information.
Well, thank you for that.
You're welcome.
One more question for Mr. Pritchard, if he doesn't mind coming back. If he didn't leave, I don't see him. Oh, there he is.
We're just keeping our distance.
I want to thank you for kind of, the itemization of our system review. A quick question. So as a parent, right, I would love to kind of feel if we do go back, not, the decision has been made, but concerning the air quality, is there a way that we can kind of determine an HVAC kind of report card for the school, each school, meaning just something that helps with transparency related to ventilation, air quality, et cetera, that would be helpful for teachers as well as families to make informed decisions based upon their comfort level with either working in a building or sending your child in a building based upon ventilation, air flow, as well as air quality.
I will definitely get with our team. I mean, we work with a great group of certified technicians that will be able to sit down and say, I know that the report that I received on the schools that we randomly did, it had a checklist of things that were done, the air temperature, the air quality, CO2, humidity. So, but before I say yes or no,
Yeah,
and give you a
I'm not
definitive
trying
answer,
to be
yes.
definitive, but
Just allow me to have a conversation with them and I'll be glad to let you know.
Thank you so much.
You're very welcome.
Madam Superintendent, I'm done.